Medtronic technologies impacted more than 72 million people in the last year, equating to 2 people every second. Harnessing the power of technology to take healthcare further, each technology has unique benefits designed to serve patients. The goal of this program is to get closer to the patient and delve into the challenges and impact of each technology in practice. This is the Medtronic MedEd learning experience. HealthCast Vital Sync remote patient monitoring and the HealthCast Vital Sync remote patient monitoring ventilation dashboard should not be used as the sole basis for diagnosis or therapy and is intended only as an adjunct in patient assessment. Medtronic's medical education programs are offered to provide attendees education on the FDA, cleared indications and use of our products when applicable. The contents and conclusions of the following program are solely those of the speakers, unless otherwise cited. The speakers are responsible for all content and any necessary permissions. The speakers received funding from Covidian LP, a Medtronic company, for this speaking engagement. For this segment of the series, a discussion around acute care and wearable technology. What's the evidence supporting wireless monitoring? To help provide insight into this topic is Dr. Ashish Khanna, Director of Perioperative Outcomes and Informatics Collaborative at Wake Forest University School of Medicine.
So you're going to ask me why I keep saying that the evidence needs to develop further. Well, there is evidence, and there's pretty strong evidence with prospective cohorts and retrospective before and after type study designs. The one with the red arrowhead is actually from our institution, where we've seen a difference in patient-centric outcomes, right? ICU transfers, cardiac arrests, rapid response team events using wireless wearable technology that I've highlighted here. However, the purists will say, well, I need to see an interventional trial, a randomized trial. Having said that, it's not easy to do randomized trials with wireless wearable technology. And I think we should digest what we have and use it to at least put in this technology and then randomize our patients. So, for example, this data comes from the United Kingdom, just published in the British Journal of Anesthesia, a before and after study. They said, okay, we've achieved a pretty significant decrease in ICU admissions and rapid response calls, and looking at a baseline period and an interventional period with wireless wearable monitoring. These are really important outcomes. This is our unpublished data. We took a large sample of nearly 36,000 patients here at Wake Forest, and we said, okay, we'll propensity match them, comparing continuous monitored patients to intermittently monitored patients. And we've seen a whole host of clinically relevant outcomes being in favor of continuous wireless wearable monitoring, including mortality and ICU admission, amongst other things. So really the data keeps on accumulating. And what I will say is, in short, is that yes, there is a lot of retrospective and prospective historical cohort type evidence. All of this lends itself to future randomized trials, which are coming. And it's only a matter of time before that kind of evidence will be there. People ask me about alarms. I would say that alarm thresholds are really important. It's really important to help your clinical colleagues understand that they can specifically design alarm thresholds to prevent alarm fatigue. This, for example, I bring up what we do at our current institution with our current monitoring system. And we've seen, so I have data in my dashboard where I can see, for example, taking 6 alarms per patient per day as a reference point. We're able to keep ourselves below that 6 alarms per patient per day, except for a certain blip up here. But again, this data came from, a COVID or post-COVID period. And despite that, we were able to achieve pretty good continuous monitoring, alarm fatigue, optimization. People will also ask you around the cost effectiveness of continuous monitoring. And I think this study that used Prodigy data is really, really relevant. And I don't think it is utilized as much as it should be utilized. So we looked at Prodigy data, and we asked hospitals to give us the exact information on the healthcare dollars spent on a adverse downstream event and the dollars spent on hospital length of stay and so on and so forth. And we estimated that it took only a few percentage points of a reduction in respiratory depression to get to a break-even point with cost savings in United States dollars in terms of a overall break-even point for a hospital, investment in continuous monitoring, and cost and a point of cost saving. Knowing that we detected 46% of OIRD, reduction by a few percentage points in OIRD would be very, very easy, right? And the different colors here show the high intermediate, and high intermediate and low risk prodigy patients. But again, pretty easy to get to break even. And then furthermore, if you can get to a greater reduction in respiratory depression, say 10% or 15%, then you're going to have lots and lots of cost savings and lots of length of stay reduction as well across all three categories.
Please tune in next week for a new segment from this series wherever you find your podcast. This is the Medtronic MedEd Learning Experience. Thank you for listening.